Well, good afternoon, and welcome to the Flint Community Webinar on coronavirus, providing a local context to this global pandemic. We've been in this for a while. The Healthy Flint Research Coordinating Center is sponsoring this, along with the Flint Center for Health Equity Solution and the Prevention Research Center. I am excited today to be back with you. I'm your moderator for today. It's been a few weeks since I've seen you, so I want to appreciate those of you that filled in. Heatherlyn, for doing such a great job, and Dr. Jennifer Edwards-Johnson, thank you so much. And it is a pleasure to be back with you today. We have an exciting event for you today. We have wonderful presenters that are going to share some great news with you. And so we're, again, always appreciating our Flint partners who have been with us for these now 131 weeks. And who knew we would be continuing this webinar during this time. Trusted, credible messengers who are here to share information with you. Today, as I mentioned, we are looking forward to a great conversation. We've got some wonderful panelists who are going to talk to you about the underinsured and the uninsured and what benefits are available to them, kind of what's happening in that world of the uninsured. We're also going to hear about stroke today. We're going to hear some information about just digging a little bit deeper into some of the issues that are facing us today. And so we want to get really started because we've got so much to cover today. We want to get started with looking at covering the under and uninsured. We have a great dynamic duo that's going to be with us this afternoon, and that's Jim Melanowski, who is the president and CEO of the Genesee Health Plan. And we're also going to have in the room with him is Stacy Doyle. Stacy Doyle is the executive director of the Free Medical Clinic. And these organizations have worked closely together. So we're going to ask Jim Melanowski to start off for us today with information about covering the uninsured and the underinsured. Good morning.
Thanks, Yvonne. Can you hear me? Can you hear me okay? Great. Thank you. When COVID-19 hit in 2020, a lot of people lost their jobs. They lost their healthcare coverage, or they were laid off, and so it was the federal government stepped up and they passed this 2020 Families First Coronavirus Act, and how it impacted people here in our community and in Michigan was that the federal government offered higher reimbursement for Medicaid for people. And but the states had to agree that they would keep Medicaid eligibility standards open. They wouldn't, normally if someone's on Medicaid every year, they have to go and reapply to be on Medicaid. This act made their coverage continuous. Next slide, please. So, and then once a public health emergency was declared when coronavirus hit our country, but this act allowed for that once that public health emergency ended, states would resume this normal process, and then that would end this enhanced federal funding. The goal was to cover all these millions of people who had lost their jobs during COVID and needed healthcare coverage. Next slide. So the Kaiser Foundation estimates that once this public health emergency ends and people will need to reapply for Medicaid, that there could be a potential for 5 to 14 million Americans to lose their Medicaid coverage. Medicaid in our country has grown by 25% during these 2 years because, again, of the enhanced Medicaid that's out there. So states have collected quite a bit of dollars to cover more people that needed it. And what's the good news is that uninsured rate across our country dropped to under 10%, to almost about 9% at the end of last year. And we're still waiting on this year's numbers coming up. But it's really been a great success. A lot of people got covered that normally were under some other type of insurance. and really needed coverage. Next slide, please. So, but when's this public health emergency going to end and things get back to normal? Next slide. Well, there's been talk that it would end in July, and that didn't happen. In October, that didn't happen. So again, the next best guess is going to be in January 11th, upcoming, and that this public health emergency would end. And so the federal government would give a 60-day notice, which would be in November, and then states would start their process. I know in Michigan, the state is ready to get going and alerting people that, hey, you have to reapply now. So that'll be the latest date. So in about 2 months, a month and a half, we'll know if that's going to end here in January 11th. Next slide, please. The federal government came up with this new name. It's called unwinding. So they're going to unwind the public health emergency and start the re-enrollment process for Medicaid. So unwinding. Next slide. So when I think of unwinding, that's like me on the beach, just kind of hanging out. But next slide. I think it's going to be quite a mess, actually. So this is another example of unwinding, because I think a lot of people who never have had Medicaid before, don't even know what this whole process is, are going to be asked to either comply or they're going to lose their coverage. Next slide. So what does that mean here in Michigan? So when the Affordable Care Act came out in 2015, there was a Medicaid expansion called Healthy Michigan. Right now, there is over 1 million people currently on that Medicaid expansion. 2 years ago, there was only 543. So you can see it's almost doubled in the amount of people that are on Medicaid in our state. There was 3 million total Medicaid recipients. That included children and so forth. And there's a total population of 10 million in our country, in our state. So that's like 1 in 3 people that are currently on Medicaid. That kind of is mind-boggling if you think about that. In May of 2020, just 2 years ago, that was only 1.8. So you can see this growth, this expanded Medicaid, that all these people are on Medicaid and then, wow, could lose their coverage. Next slide, please. So in Genesee County, this is kind of the numbers that we're dealing with. So in May of 2020, we had about 32,000 on this expanded Medicaid. Now we are at about 55,000. So about 22,000 more people are on that. And total Medicaid recipients, including children and adults, are at 128,000 compared to 109. So it's about 20 to 30,000 total more Genesee County residents that are on. And so really, that's really kind of the group that we're really concerned about. Next slide, please. So there could be a potential for, anywhere of about 20,000 people losing their Medicaid coverage. Again, Medicaid full health insurance. We can certainly enroll them in Genesee Health Plan. That gives them some outpatient medical coverage. They can see a doctor, get prescriptions, all those good things. But there is this worry that in next year, in 2023, people are going to start to lose their healthcare coverage that really always had prior to this, like employer coverage. The free clinic is a wonderful resource, and we have other resources in the community, like the 2 federally qualified health centers that can help these newly uninsured. But I'm not sure Stacy could handle 20,000 more folks. So, this is something that not only will we be working on at Genesee Health Plan, but working with our partners like the Free Clinic and with Hamilton and Genesee Community Health Center, those folks, on how do we address this and how do we get the word out? Next slide. So really, there is a state website. The state has made plans And if you want to go and find out what the state's plan is or what they're putting together, there is this page, michigan.gov, and you can see the rest of that. And you can get all kinds of information from the provider perspective, from the individual enrollee perspective, and as a community partner. So I would really encourage people, if they want to find out more about the latest news of how the state's going to handle this, that they go to that. And then I'm going to wrap things up and turn it over to Stacy. Next slide, please. So again, the biggest thing that I can leave everybody is that if you know somebody who is on Medicaid, make sure that they're giving a change of address back to their local DHHS office, or so that they have their most current contact information. That will help the most with this. So I'm going to turn it over to Stacy, and she can talk to you about what they do at the free clinic with the uninsured.
Thank you, Jim. Thanks, Yvonne. At the free clinic, we see, again, those patients that are newly uninsured or underinsured. Some of them may have high deductibles and medications. That's where we see the underserved is they may have high deductibles for insulin and other medications. In the free clinic, through the dispensary hub of hope, is able to supply them with some of those chronic medications that they need for their chronic conditions with the no fees. We are open to the community for those uninsured and underserved 3 days a week. We have McLaren residents and attendings at the free clinic 3 times a week for half a day. And then we have some fill-in hours, an evening clinic and a second clinic on a Wednesday. But I could go on and on for all the services that we have here. But how it ties into our great partners, Genesee Health Plan, is even with COVID-19, we've found that a lot of the patients, they're still learning how to take control of their primary health care. So they're getting high blood pressure, high cholesterol, diabetes, all of those things. And certainly the clinic is there to get them on board and get control of their healthcare issues. But one of the great things about the partnership with GHP is when a new patient comes to Genesee County Free Medical Clinic, they're made aware that we are their temporary healthcare home. And within 90 days of becoming a patient of the free clinic, they are required before they get any referral services or anything like that to meet with the Genesee Health Plan representative. Because again, some of the patients need to be seen by a physician that can see them 5 days a week, not just 3 days a week. So the partnership is invaluable. Sometimes a patient has been to the free clinic that hasn't seen a primary care physician in 10 years. And the staff that help our patients navigate and apply for GHP and some of those other state programs, as Jim mentioned, Healthy Michigan and Medicaid, the representative from GHP is so helpful in helping them navigate the system and get that application and find a permanent healthcare home for them so their healthcare issues don't escalate and things don't get out of control. So it's been a great partnership. It really does help our patients feel empowered that they can navigate their healthcare issues and the system with the help of GHP and Genesee County Free Medical Clinic. We also enjoy the partnerships, again, with COVID-19 and especially flu and other things, is the partnership with access to get those vaccinations, to get those healthy maintenance items that they can't get anywhere else without insurance. So it is truly just a circle of programs to help the patients of Genesee County.
So Stacy, do people have to have, what's the process that people would use to get in touch with you?
They are on our website. We're by appointment only.
Mhm.
So they can contact us via website or our brochures that Genesee Health Plan has, and different healthcare communities have our program, our promotions and website. They call and make an appointment. We do have some criteria that they have to meet. They have to have an ID. They have to have a social security card. We will see those patients that are undocumented. They have no place else to go. So sometimes there isn't that social security card or ID, but we will see them on a limited basis. So nobody is going without health care. That's a great question. So they call our office. We're open 5 days a week, but we only see patients 3 days a week. So they should be able to contact somebody at the clinic even 5 days a week.
Great. And so, Jim, just one other question for you with respect to the unwinding. When we look at what's going on, what is the process that the Genesee Health Plan will use to help those individuals during that process?
Well, again, I think trying to get the word out before and educating people on that they're going to receive a letter, and this is what the letter kind of looks like, and making sure that they have so a lot of preventative, make sure they have a change of address if they've moved in the system. And then it's really our staff, and there's other enrollment staff throughout with our enrollment partners like the Greater Flint Health Coalition in Hamilton, can help people enroll into Medicaid or help them re-enroll. So, because there's certain requirements, and so then those all get put into the state system. So it really is a two-prong approach, educating and then helping and assisting to make sure people keep their coverage.
Thank you so much for this dynamic team that's come together today to talk about what's happening with the insured, with the uninsured and the underinsured, to know that there are resources available in the community to support them. And we'll talk a little bit more about some of those additional resources as it relates to testing and sites that people can go to in just a little bit. So thank you, Jim, and thank you, Stacy, for being with us today. And Stacy, you mentioned something about people having chronic illnesses, the fact that there's some things that are going on that they need to see a regular physician for. And so today, following your presentation, we have Dr. Leslie Scalaris, who is a professor of neurology at the University of Michigan, and she's going to talk to us about stroke, being stroke ready, as one of those chronic illnesses that seems to have even increased during COVID.
Awesome.
Thank you so much. Can everyone hear me?
Yes.
Okay, terrific. All right, great. Thank you, Yvonne and Heather, Lynn, and the team for inviting me. I'm delighted to speak to you today on behalf of myself and one of my community partners, Elder Sarah Bailey, on everything to know to prevent a stroke and to get a stroke treated. Next slide. Terrific. So I think it's helpful to start with the take-home messages right at the beginning. So what we think is most helpful is to recognize that stroke is an emergency. Then we're going to talk about recognizing the signs of a stroke, how the clot busting drugs work, why to call 911, and then finally end with some reminders about how to prevent stroke. Next slide. So first, stroke is really common. So there's about 800,000 strokes every year. So Dr. Young is probably cringing at this picture, given this is Michigan's football stadium, but Michigan's football stadium houses about 100,000 people. So that would be filling up Michigan's football stadium 8 times. It would be the number of strokes that happen each year. It's a leading cause of, apparently Dr. Young is a great Michigan huge football fan. Okay, terrific. Maybe I'll make it bigger than next time. Stroke is a leading cause of long-term disability. Next slide. There are 2 kinds of strokes. There are hemorrhagic stroke, which is bleeding, basically a blood vessel burst in the brain causing blood to pool. And then there's ischemic stroke, which is a blockage. So blood flow is stopped. And then the blood flow distal to or downstream from that blockage, that brain isn't getting any blood, and that area of the brain dies. Next slide. We're going to primarily focus on the blockage kind of stroke, given that that's about 80% of strokes, and that's the kind of stroke that you would want that we have clotbuster drugs that treat. Strokes are common. They're common in everybody, but they're particularly common among Black Americans who have about a 1.5 times risk of having a stroke as white people. I think for me, in my clinic, I think the second important point is that Black people typically have strokes at younger ages, given that oftentimes stroke affects not only the patient, but the whole family. This has sort of ramifications for people's entire social network. Next slide. So what are the signs of stroke? I get this question all the time of why isn't stroke just like heart attack, where we just have a couple of signs, mostly pain. And it's because that the brain is more complicated than the heart. I tell my cardiology colleagues, but basically different parts of the brain control different physical and thinking functions. And depending on what part of the brain isn't receiving blood flow, that's the different symptoms that strokes present, that people having stroke have. Next slide. So we're going to go over the most common symptoms to help everybody recognize these symptoms if they were to see them, identify them in themselves or in someone else. They're remembered by this acronym FAST. F is for face, A is for arm, S is for speech, and T is for time to call 911. Those 3 symptoms, face, arm, speech, are the most common symptoms associated with stroke. Next slide. So F is for face. So the way that one would check for this is to look if someone's face is drooping or twisted on one side. You can sometimes see that with just talking or looking at them, but sometimes you'll need to there are ways to test for it. So it would be to ask someone to smile or to close their eyes. If they smile and only one side of their face is going up, that's a sign that they have that their face is weak, and that could be a sign of a stroke. Next slide. A is for arm or arm weakness. So this would be as someone's arm weak. And the way that we test for that is that if we ask people to hold up their arms, if you see one arm droop down, that's a signal that arm is weaker than the arm that remains up, and that might be a sign of a stroke. Next slide. And then S is for speech. This is for slurred speech. So people that aren't pronouncing all their words or their letters succinctly, or it's also for sort of mixed up speech. So you'll ask the person a question and they'll answer something that's totally irrelevant. So you would ask them, what's the name of their dog? And they would say the sky is blue. Or it would also be, or the other sign is that if you would ask somebody to repeat something. So we often say today is a sunny day, and they won't be able to repeat that. That's a sign that their speech is impaired. Next slide. And then T is time to call 911. So if you see any of these signs, these are signs of a stroke. They're signs of a disabling stroke, and it would be time to call 911 for those. Next slide. Next slide. I cut the video because I didn't want to take up too much time. So what do you do if you see these symptoms? What can we do? So I think that before 1995, so there was really, people would go to the hospital and we would just help them prevent having a second stroke. But in 2022, there are many things we can do. The first option is a clotbuster drug called TPA. So we're using this analogy of a kitchen sink and the drain pipe is clogged. So basically water's coming in, there's that brown, let's just call it, I don't know, dirt in there that's clogging the sink, and then the water can't get past that. That's the same thing that happens with the stroke, is the blood can't get past that blockage. So we give them the medicine. It's an IV medicine called TPA, and it's signified here by these yellow circles, that the TPA is going in there and it dissolves the clot such that the water, or in the case of the brain, the blood flows without that blockage anymore. So I sometimes think of TPA as Drano, for the brain. So we're kind of using Drano to clean out that clot. Next slide. It's important because after that blockage, that brain isn't getting any oxygen or any of the nutrients that it needs to work. So we need to sort of get that blockage out, so to make sure that that brain can get the food it needs to keep living. Next slide. Next slide. So this is a companion to the cartoon we showed to show you what it looks like in the brain. So basically, here's the artery, the first the slide. Then the sort of star is the blood, is the TPA, and then you can see the blood flowing through. It's just sort of give you another visual example of what that blockage looks like and how we can make it go away. Next slide. So people have about 4.5 hours to get to a hospital after the stroke starts. These medicines or in these procedures we do work better the faster that they're given. And it takes about an hour in the hospital for the most part to give them. So we say out to 4.5 hours, but it's really in the first 3 hours. And really we'd like people to come to the hospital in the first 30 minutes. So next slide. So TPA works better the faster it's given. Next slide. So you can see here, I tried to show this in a visual in a graph. So if we look here on the x-axis, or on the bottom, is time from the start of the stroke. And on the y-axis, or the up and down axis, that's the chance of recovery. So you can see that the chance of recovery goes down as time goes by. So the sooner the person gets to the emergency department and receives the medicine, the better the chances that it will work and they'll have less disability. Next slide. We often get a question of, can we just drive to the hospital? Why do we have to call 911? And this is something that we've thought about a lot in Stroke Ready. And we've ended up saying that that calling 911 is important. It's important for a couple of reasons. One, paramedics know how to treat a stroke. So there are some strokes that get worse over time. And so it would be really hard to help safely transport your loved one when they're getting worse and you're trying to drive. So I think for that reason. And the second reason is probably equally important, is that Flint has a really impressive pre-hospital alert system. So when the ambulance picks up a stroke patient, they will call the hospital. So they'll call Hurley, they'll call McLaren, they'll call Genesee, and tell the emergency room that they're bringing in a stroke patient. So that gives the hospital time to get ready. So oftentimes the stroke team is waiting for the hospital, waiting in the emergency room for the patient to come well before the patients even arrive. So they're kind of, I'll often at Michigan be there before the patient. So we're just waiting to sort of so we can do whatever we can to decrease that time as well. And then the most important thing that you could do if you call 911 is to remember the time when the stroke symptoms start. You'll get asked this a million times by people, from the paramedics to the ER nurses to the ERNAs to the ER doctors to the stroke doctors. They're going to say, when did the symptoms start? Because being earlier is better. And so that's the most important information you can provide. Next slide. We often hear the question about, what if stroke symptoms go away? So there's a thing called mini strokes, or TIA. They have about the same, they have the same signs as a stroke, but they last less than 24 hours. Mostly they last like 5-10 minutes. We still recommend going to the emergency room then, because those are warning signs of a stroke. And there are things that we can do to prevent you from having that stroke. So it's important that even if the signs and symptoms of stroke go away, you still seek care, because there's opportunity to prevent you from having a stroke. Next slide. Okay, now we're going to move to stroke prevention. So what can you do? What can one do to prevent a stroke? Next slide. So there are many things you can do. So there are many risk factors for stroke: high blood pressure, diabetes, tobacco use, obesity, being physically inactive, high salt diet, stress. I think that the number one is high blood pressure. So if I had to pick the one thing that is not just me, if the world had to pick the one thing that's driving stroke, it's high blood pressure. Next slide. So what does that mean? How do you know if you have high blood pressure? So you can take your blood pressure at home. You can take your blood pressure at the pharmacy. You can take your blood pressure, ask for a blood pressure check at the clinic. So it's really a numbers data game. So you can identify it by taking your blood pressure. Next slide. And then what does that mean? So we use all these words, but basically the top number is your systolic blood pressure and the bottom number is your diastolic blood pressure. And we really want it less than 130/80, those numbers. And the other language that we use, which is confusing, is high blood pressure is the same as hypertension. So those are the same words. I don't know, like the English language often has the same words for mean the same thing. This is one of those cases. I find it particularly annoying personally. Okay, next slide. So what do you do? So if your blood pressure is less than 120/80, awesome. Keep up the good work. Well done. If your blood pressure is in this borderline zone between 120 to 130, you have borderline hypertension, you can talk to your doctor at your next appointment and then consider lifestyle modification. So eating less salt, more fruit and vegetables, maybe exercising more. This will help lower your blood pressure. If you're in the high blood pressure range, which is 130/180/80 to 120, you should talk to your doctor. You should see your doctor within the next month. If you're not on medicines, you might need to start medicines. If you are on medicines, you might need to change them or increase them. We would also recommend the same lifestyle modifications. And then finally, if your blood pressure is over 180/20, you should call your doctor right away. You'll likely need to change or adjust your medicines. And then if you're having symptoms, such as stroke symptoms that we just talked about, chest pain, you would need to call 911 because this can be a sign of a hypertensive emergency. Thank you so much. It has been delightful speaking with you. I will answer questions in the chat and I'll be here for them.
Dr. Scalaris, we do have one question that maybe you could answer.
Oh, I do. Okay, cool.
Yes, it says, can you please explain the systolic and diastolic? What do those numbers tell us?
Yeah, sure. So good question. I only even brought that up because I think that sometimes doctors use them, and I think they're, so I just wanted you to know what that means. So, but basically, so systolic is when the heart is squeezing. So it's the blood pressure when the heart, it's the pressure in the arteries and when the heart is squeezing. So it's like squeezing your blood out. That's the systolic. The diastolic is when the heart is at rest. So basically the heart has to fill back up with blood, and the blood vessels relax. So that's the diastolic blood pressure. If I had to pick one that's most important for stroke risk, it's by far the systolic. So that's the one that we mostly care about, is that top number. The bottom line number, I think is less related to your risk of stroke and heart disease, but the top number is the number we most care about.
Thank you, Dr. Scolaris. And have you seen an increase during these last few months, particularly during COVID?
Yeah, that's a good question as well. I think that the epidemiology, or I think we don't know is my fair answer. I think initially we saw less stroke, but I think that was because of less people were coming to the hospital, to be honest with you. I don't think it was real. And then subsequently, then we saw more stroke because I think all those people who had strokes were now felt comfortable getting treated. And now it seems to be coming back to sort of the pre-COVID levels. And so I think so I think it's hard to tell at this point.
Okay. We just want to encourage people to follow these recommendations and just make sure that they're doing the things to take care of themselves.
Cool. Thanks, everyone. I'll be around.
Thank you. And so again, for any questions, please feel free to put those questions in the Q&A, and our team will be able to answer those for you. We're going to move now as we continue to talk about chronic illnesses. We also want to talk a little bit about boosters, and we're going to welcome Dr. Susan Woolford to talk to our team. Oh, and she's got, oh, can you see us, Dr.
I
Woolford?
can't see you.
My goodness, Dr. Woolford, what's going on?
Good afternoon, Yvonne.
Good afternoon.
And you ask, why am I blindfolded? So I am blindfolded today because so many of us are in the dark about our chronic illnesses.
Yes.
Did you know that about 1 in 3 people who have high blood pressure don't know they have it?
I did hear that.
And did you know that about 8 out of 10 people who have pre-diabetes don't know they have it?
I did not know that.
So we are in the dark. And today we are going to be digging deeper into these issues of chronic illnesses so that we no longer have to be in the dark, that we can have more information so we can make good choices and be able to improve our health. And so with that, we are going to dig deeper into this question of chronic illnesses and COVID, starting off with Dr. EJ. So I believe there we go. We'll bring Dr. EJ on. Thank you so much for being willing to speak with us today some more about chronic illnesses. This is a wonderful way to build on all that great information that we just heard from Dr. Scolaris. And we know that, as we said, many people don't know they have it. Even those who know they have them don't really know sort of how well they're doing with it or not. And so let's start off with, maybe you can just describe for us or explain what are chronic illnesses.
Thanks, Dr. Woolford. And Dr. Scolaris did like an amazing intro into this, right? We talked about high blood pressure and particularly how it affects diverse populations, Black and Brown populations. When we think about chronic illnesses, these are conditions that usually have been going on for about more than a year and require ongoing medical attention. So these are things that you need to be checking in with your doctor about regularly. And there are things that aren't quickly managed in, a week or even a month. There are some definitions that will use 3 months as sort of the defining barrier of when a chronic condition can be diagnosed. But the key piece is that this is something that requires ongoing medical attention and that you need to check in with your doctor about regularly.
Thank you so much. And so what things should you do to make sure that your chronic condition is well managed? I mean, first of all, how do you know you have one? And what can you do to make sure that they're managed well?
I think that's a great question. And again, Dr. Scaleras, though she's from U of M, I'm a Spartan, it still gave us some great advice on. I think knowing your blood pressure, taking your blood pressure whenever you have an opportunity to, right? Knowing some of the common medical conditions. So we know high blood pressure or hypertension is a common medical condition. We know diabetes is a chronic medical condition that we should be thoughtful about. The biggest thing, though, is having a primary care provider, because when you have a primary care provider, they're being thoughtful about the screenings that are appropriate for your age, your risk factors, and what chronic conditions that you might need to be thoughtful about.
That's awesome. And so if you have a primary care provider, and hopefully if you don't, we had some ideas today about how we can get one. How often do you need to go and get a physical?
So that's a great question. You should be getting a physical about once a year. But when we talk about chronic medical conditions, if those chronic medical conditions feel like you don't have a good handle on them, you're not quite sure what what metrics you should be looking at, what labs you should be getting, you're not quite sure if those labs are where they should be. Typically, as a primary care provider, I'm seeing those patients every 3 months, right? I'm checking in with them to make sure that their diabetes is well controlled, that their blood pressure is well controlled, and we're checking in on those things every 3 months. For high blood pressure, if we haven't gotten that under control at that number that Dr. Scaleras talked about, that 130/80, if we're still kind of not below there, I might check in with you with a phone call every week or two until we get you well controlled, right? But generally, chronic conditions that are uncontrolled, we go every 3 months, and every 6 months for those that have better control, right? So if your diabetes or your COPD is well controlled, we'll do a check-in every 6 months to make sure that it's still well controlled.
Right. So do I understand you correctly? If no chronic conditions, then every year. If chronic conditions that are well controlled, every 6 months, and then chronic conditions that are not well controlled, every 3 months.
Absolutely.
All right, wonderful. Well, thank you so much for that awesome information. Before we bring in Dr. Harris into this conversation, I just wanted to ask, with those well visits, I almost said well child checks because that's what pediatrics, but with those well visits and those physicals, what screenings should we expect to have done at those visits?
Absolutely. I love for patients to be well informed and know what they're expecting when they come in. The screenings are going to be different by age, by gender, but largely the big ones we want to be thoughtful about is you should be getting your blood pressure checked, right? There are a set of labs that a lot of people will get checked during most labs. So we will often check your cholesterol, we'll check your risk of diabetes sometimes we'll do that with a test called an A1C, or we might just check a blood sugar level, right? And so we will get a set of labs that sort of make sense based on your age and your gender, et cetera. It's also important to make sure we're being thoughtful about breast cancer screening, depending on your age, right? Cervical cancer screening, depending on your age, colorectal screening. So that's screening for colon cancer. So we'll often be really thoughtful about that. And those are kind of the screenings that are most common in our age groups and things that we should be thoughtful about. If you are someone who is at high risk for skin cancer, sometimes, definitely during your physical, we'll be doing a full skin exam to make sure there are no lesions that we should be concerned about. But that's the majority of the screenings that we talk about.
That's so important. I remember it was through one of those screenings that I found out that my blood sugar was creeping up. And of course, it gives you, you say to yourself, well, why do you need to go for these physicals? Well, that's exactly why, because then you can sort of, take charge of that and, have less of those things that raise the blood sugar, do a little bit more exercise, make a difference. So you can avoid developing these chronic illnesses and being at risk for the many things that we're talking about. So let's bring Dr. Harris in now. Dr. Harris is new to our panel. I'm so excited to have her. Don't leave, Dr.
No, I'm not leaving. I'm just saying hi.
Oh, righty. Yes, welcome to Dr. Harris, who, just for those who may not have met her before, she was born and raised in Flint, Michigan, and is back there now serving as a family physician. At family Harris Family Health, right? Is that correct?
Yes. Yeah.
Yes, and so we are so glad to have you with us this morning. And we wondered, we've been having a lot of questions about chronic illnesses and about boosters. Can you share with us a little bit about what we need to know in that regard? And, you know, if our chronic illness is well managed, do we even really need boosters?
Yeah, so specifically with COVID, just like a lot of the other vaccines that people have gotten over the years, sometimes the immunity does kind of wane and decrease, and so your protection's not as good. So we always encourage people to get boosters to keep that immunity and keep your immune system as strong as possible. When it comes to chronic conditions, just like Dr. EJ was saying, like, you do need to check in on it on a regular basis to make sure it's well managed, but all because you have it well managed doesn't mean that you don't still need protection from different vaccines, specifically the COVID vaccine. And so we don't want people to have flare-ups, have moments where their chronic conditions are not as well controlled. And so we love for people to get their booster, so that way, at least with the COVID vaccine, the COVID infection or other infections, that they're as protected as possible.
Wonderful. Thank you so much. And now we're going to bring Dr. Young in as well. And while we do, if you have any questions for our doctors here today, please feel free to put your question in the Q&A. And Dr. Young has been with us before, and we're so glad to have him because as an OBGYN, he has specific expertise that we would like to tap into today as we think about pregnancy and boosters and the vaccine. What could you share with us in that regard?
Good afternoon again, and thank you for having me. And I think the decision to move forward with the vaccine is like any medical decision that patients have to make. It's a risk versus benefit. And in this case, it's, am I comfortable with the risk of COVID infection in pregnancy, which we know has an increased risk of preterm delivery, stillbirth, ICU admission requiring ventilation, and other obstetric complications. So those are well documented. We have 2 years of data that show that there are poorer outcomes of pregnant women with COVID-19 infection.
Can you repeat that one more time? That's so important to hear. If you get COVID while you're pregnant, what are the increased risks?
Increase of preterm delivery, miscarriage, stillbirth, ICU admission requiring ventilation, and other obstetric complications, including hypertension, preeclampsia. And the data supports that, and I've seen it in my own day-to-day practice. So
such an important reason to, because many people sort of say, well, you know, COVID's not a big deal. I can get it and I would just be fine. But what if you give it to a pregnant person? They're increased risk for all of these things. Sorry, didn't mean to interrupt.
No worries. So again, when I'm counseling a patient, I put that into context of these are potential risks and outcomes. And if you're comfortable with that, that's fine. But I want you to be aware that those are the risks associated with COVID-19 infection and pregnancy. And now when we go towards vaccine and pregnancy, so I try to put it in the context that there are well-established vaccines that are safe in pregnancy. So we offer the Tdap vaccine in the 3rd trimester, and then the influenza vaccine, which is safe in pregnancy at any point. But from a practical standpoint, and again, it's fair, the initial studies on safety of COVID-19 vaccine pregnancy did initially have women who were attempting to conceive or who were currently pregnant. But the CDC has had an ongoing registry of pregnant women who have received the COVID-19 vaccine, which is called V-Safe. And their data has shown that there are no increased risks of stillbirth, birth defects, miscarriage. So those outcomes that every mother is worried about, whether it's taking Tylenol or any other medication during pregnancy, they want to know, is this going to cause me to have a miscarriage? Are my baby going to have extra digits? Or is it going to worsen my own health during my pregnancy? And this data that we have so far through the V-Safe registry show that there have been no increased poor maternal or fetal outcomes. From a practical standpoint, when I'm talking to a patient, like most interventions that we introduce in a pregnancy, I usually tell moms that I recommend waiting until the second trimester when you reach viability. So you don't leave any doubt to say that, hey, I got the vaccine when I was 10 weeks and then now I'm having spotting or whatever it is. So I usually, from a practical standpoint, have the mom and the family more comfortable decision. I say, let's just wait till the second trimester. Let's wait until after viability, and then we can have another discussion about introducing the vaccine. But current CDC guidelines, the American College of Obstetricians and Gynecologists all recommend healthcare providers to educate and promote the vaccines, the initial vaccine series, and the newest boosters that we have available. And then also monoclonal antibody therapy, and also the new outpatient oral regimen too is recommended for pregnant women who have mild to moderate COVID-19 infection that doesn't require hospitalization.
That is such awesome information. Thank you so much. We've run out of time, I believe. And so there's so many other questions I think we'd like to get to. Definitely, we would love for you all to come on back and so that we can dig deeper into more of these important issues. But with that,
Dr. Woolford, I think you actually do have a time for a couple of additional questions.
Oh, excellent. Well, with that, so one of the things that we wanted to ask about was about long COVID and vaccines and boosters. So any thoughts about that? Dr. Harris, any information about long COVID and vaccines and boosters?
Yeah, so I did want to begin specifically with long COVID. We are learning about it more and more each day. And just from the patients that I've cared for, some of them only have additional symptoms for a short period of time, as far as multiple months, and some of them still have symptoms a year plus out. And so as much as we like to shorten the idea that long COVID will go away, for many patients, it is going to become a chronic problem for them, as Dr. EJ was talking about, as far as lasting for over a year, that you have to be aware of and be cognizant of how it's impacting your other medical conditions. And so with that, getting the booster and keeping your immunity up will help you from getting COVID again, because all these variants make it easy for people to get it again. And I've seen people who've had it a few times. But when they have the booster, it is able to make their symptoms and their recovery a lot easier. And so as long COVID kind of exists and we're learning more about it, I definitely encourage people to keep themselves protected and keep their chronic conditions that they had before COVID manageable, and keep checking in with their primary care doctors so they're able to make their self as healthy as possible.
Excellent, thank you. Do I have time for one more?
You're good.
We're gonna go with one more. Just because of the time of year, it is flu season, right? And so I just wanted anybody, maybe Dr. EJ, any comments about getting your flu vaccine now, with relationship to getting your COVID booster and chronic illnesses? Any thoughts there?
Yes, absolutely. I've diagnosed the flu, so yes, flu is here. You should get your flu shot. If you might have seen in the news some thoughts that maybe flu might be either worse or more prevalent this year. And you have to be thoughtful, right? We've rolled back a few restrictions. We're not masking like we used to. And so your risk of really any respiratory illness is probably a little bit higher because we're not being as careful as we were in the thick of the pandemic, where many people aren't and the restrictions aren't there. So being thoughtful about making sure you get your flu vaccine to be protected, because I'm seeing it even in your kiddos, and my kiddo fought me about getting hers. So
thank you so much. I feel like we just, without Dr. Reynolds here, we just need to say the layers of protection.
Yeah,
everybody who listens knows what that means, and we need to use all of those layers to keep ourselves and our children and all those we love and even those we don't safe during this season. All right, so with that, I'll say thank you again to Dr. EJ, Dr. Young, and Dr. Harris, and over to Yvonne.
Thank you, Dr. Woolford, and all the doctors that shared with us today. That is great information, and we appreciate hearing that. And so we're going to go now to look at what the data says to us about what's happening in Flint, Genesee County. So Alan's here with us to give us that update.
Yeah, thank you for having me. A quick shout out, many moons ago, I hosted an open mic night where Dr. Asia Harris would come and perform her poetry. So it's like all these worlds combining here. So The number, I feel like a broken record again. There is just a sustained number of COVID cases happening. Some are saying the actual numbers much lower because of the at-home testing increase, but the patterns are still the same. So we do just have a sustained number of COVID cases each week happening.
Thank you, Alan. I appreciate that insight. So we want to make sure that we maintain getting those tests and getting those vaccines and making sure that we are doing the things that that keep us healthy. We also want to now go to the health department. And I know that our representative that normally is here is not here, but Kaylee, we'd like to ask if you could come and give us an update. We know we have clinics that are coming up.
Hi, everybody. Sorry, I didn't know that I was going to be expected to give clinic dates, so let me pull those up real quick. While I look for those, we do
They are on the screen, Kaylee.
We do have the updated bivalent booster vaccine available at all of our clinic locations. I do want to make it clear, because just like when the first vaccine came out, there are age differences in eligibility for both vaccines. For the Pfizer vaccine, that is eligible for 12 and up. The Moderna vaccine bivalent right now is available for 18 and up. So those kiddos that are 12 to 17, they will be getting Pfizer. Moderna will be shortly submitting data on those younger folks, and it is expected that eventually that vaccine will be available for the 12 and ups. But right now it is just the Pfizer vaccine for 12 to 17-year-olds. And then for anyone 11 or under, it is still the original COVID vaccine that is available for those age groups. And as we move forward in the process, just like last time, there will be data submitted on the kids younger than 11, and eventually the vaccine will be approved for them as well.
Thank you. And we also want to let individuals know that are listening to us today, our regular clinic sites in our community are still open and available at Word of Life Church, Bethel United Methodist Church, and Macedonia Baptist Church. They are still available for those that are looking for those tests. And you do not have to pay for those. Also, other testing and vaccine sites we know are Walgreens, Hamilton Community Health Network, and Rite Aid. So we do want to encourage you to utilize those sites as you are in need. And then we also have additional contact at the health department. If you need any additional information or you need any additional help, you can call them at 810-344-4800. In both Spanish and English is available. So we want to just make sure you have all that good information today. And we're going to ask Dr. Woolford to come back and give us an update really quickly of something that's coming up in a couple of weeks, the research symposium for the Healthy Flint Research Coordinating Center.
Thank you again, Yvonne. Yes, we want to highlight this really important event on September 30th. The place to be is at the riverfront in Flint at the conference center there. We will be having, I believe it is our 5th annual, but our 3rd in person, research symposium. And this is for the community and for those in academics and for those in government. It is for everybody, anybody who is interested in improving health in Flint. Please register. Registration ends on Wednesday of this coming week, I believe. So because we need to give numbers to the caterers, etc. So please do register, get your friends and neighbors to register and come on down. There's going to be a fabulous keynote presentation. We've got panels, we have networking opportunities. We'll be giving awards. Many of you on this call have made nominations, so we'll be making those awards on that day. Just a really exciting event. It's going to be something you don't want to miss.
Thank you, Dr. Woolford. And we want to thank all of you for joining us today for this 131st webinar of the Healthy Flint Research Coordinating Center. And we want to remind our community health workers and our social workers to stay right on the line and make sure you register for those continuing education units and those social work credits. Again, we want to thank you for tuning in to us today for this webinar. We'd like you to continue to follow us, like us on Facebook, subscribe to the YouTube channel, or you can email us any questions that you might have at info@hfrcc.org. New number to call us at 810-777-5932, 810-777-5932. Call us if you have any questions or need any additional information, and we'll look to see you. We will be here next week. Thank you for joining us today.